Hello, ladies and gentlemen, and welcome to this new webinar, PCR, dedicated to the use of drug-coated balloons, dedicated to how and when we should consider the use of drug-coated balloons to treat de-novo lesions. This is a webinar produced by PCR with the support of Medtronic. The learning objectives of this meeting today are to know which kind of vessels with de-novo lesions could be considered for a DCB-alone PCI strategy, to know how to prepare the vessel properly to deliver the therapy and evaluate immediate results after only balloon PCI, and to know about the safety, which kind of complications may happen, and when to cross over to stents, and the long-term results of this strategy. It's a pleasure for me today to share these 60 minutes with two friends and very expert colleagues in the field, Dr. Fernando Alfonso from el Hospital Clínico Universitario La Princesa de Madrid. Hello, Fernando, from Madrid. And Dr. Darren Bailout from the University Hospital in Galway in Ireland. So they, as you know, are very expert in the field and will be there to share with us the cases we will discuss. And I invite you to actively participate through the link that have been provided for asking questions. So why should we consider using drug-eluting balloons without stents in de-novo lesions? Because since the early 90s, we have been implanting stents. 10 years later, at the beginning of 2000, we put drugs on that. But it's more than 30 years that we are doing the same thing. And I think that a different medical practice is transforming a diffusely infiltrated atherosclerotic conduit into a well-functioning arterial vessel, and not into a diffusely infiltrated metallic conduit. And this diffuse disease, especially of the LAD, remains a challenge for both PCI and surgery. Have a look at this vessel in a young patient we did many years ago. The vessel was so diffusely infiltrated that we treated this young guy with one single BVS, absorbable scaffold in the proximal part, and all the rest of this LAD was treated with drug-eluting balloons. This is the artery 4 years later, when the patient came for an elective angiographic and intravascular imaging follow-up, which is really incredible. There is really nothing left behind in this LAD in a patient who is now hardly 50 years old. Diffuse atherosclerosis of the LAD is an unsolved problem for revascularization, both for metallic stents and for cardiac surgery. And I think that the reconstruction of the artery wall, leaving nothing behind and the vessel open, could change our practice and the long-term outcome of PCI as we intended it today. Of course, this will be provocative, as we always want to be in a webinar, but we will address the science behind this strategy and share with you cases for a lively discussion. So I ask Fernando, please, to start showing us the evidence supporting drug-eluting balloons in de-novo lesions.
So thank you to everybody. Thank you for putting together this beautiful webinar. Thank you, Flavio, for inviting me to put together the evidence. So it is very clear that we can use drug-coating balloons, but today, my role will be to emphasize why we already got enough evidence based on good clinical data. So this is the document of the last clinical practice guidelines on revascularization, and we all know that both drug-eluting stents and drug-coating balloons are considered 1A indication for patients with in-stent restenosis, either bare metal or drug-eluting in-stent restenosis. And we also know these guidelines suggest that intracoronary imaging may be of major value to tackle underexpanded stents and to address some mechanical problems. Well, the evidence in favor of that is summarized by this meta-analysis, is patient-level data from Castrati in Munich. You may see the Daedalus trial, 10 randomized clinical trials, 2,000 patients, beautiful results with drug-eluting stents, and also very good results with drug-coating balloons. So only putting together this large number of patients, we found in this meta-analysis that drug-eluting stents are a little bit better regarding target lesion revascularization, but this only applies for drug-eluting stent in stent restenosis, because the data in patients with bare metal in stent restenosis are equivalent with the two strategies. So this is just a reminder of how these devices can be used in patients with stent restenosis, because we avoid another metal layer. Now, this is a consensus international document on the use of drug-coating balloons, and you may see here that to use this technology, we need to prepare the lesions, and this will be discussed by Flavio and by Darren. We need to prepare the lesions very well, because if there is a major dissection, a clear suboptimal result, perhaps it's better just to go and proceed with drug-eluting stents. So lesion preparation is very important. So where is the evidence? So this is the largest study. This is the basket small 2. Nearly 800 patients with de-novo lesions in small vessels, and small were defined less than 30 millimeters. And you may see here how in this non-inferiority trial, the primary endpoint was met. So there was drug-coating balloons were non-inferior regarding MACE at 1 year, as presented here, but we also got data at 3 years follow-up of this study with equivalent clinical results for small vessels. So this is another study in another randomized clinical trial in small vessels from Bernardo Cortese. And here they compared in small vessels drug-coating balloons with last generation drug-eluting stents. But here we perform a late angiographic systematic follow-up, so that the lay lumen loss was actually better when we use a drug-coating balloon, and this is very clear. The more you gain, the more you lose, but eventually at the end of the follow-up, the percent diameter stenosis and the minimal lumen diameter at follow-up was similar in the two arms. So this is confirming angiographically the basket small 2 study. So this is the last study I'm going to present, also very important, published in Lancet by Risanen. And this is 5 sites in Finland, and this is very selected patients with a high bleeding risk. At that time, for those patients, we were using bare metal stents. Well, in this study, they compare the use of drug-coating balloons versus bare metal stents in these very high-risk patients, where they try to shorten the duration of the dual antiplatelet therapy. And as you may see here, the primary endpoint, a combine of cardiac death, myocardial infarction, and ischemia-driven target lesion revascularization was actually better in the drug-eluting balloon group. But to put all this information together, this is a meta-analysis we performed with Slan El-Hendi, as you can see here. And please notice that we included 14 randomized clinical trials in patients with de-novo lesions, 2,500 patients with a mean follow-up of 1 year. So the summary is here. There is no difference regarding target lesion revascularization when we compare all these trials, the use of drug-coating balloon versus alternative strategies. There was no difference in treatment effect according to the indication, namely small vessel disease, acute myocardial infarction, bifurcation, or, as we discussed, patients at high bleeding risk. And when we compare only the trials that were the comparator was a drug-eluting stent, again, target lesion revascularization was similar with drug-coating balloon than with drug-eluting stent. So this is very briefly the findings. This is the angiography findings. You can see here at follow-up, similar minimal lumen diameter. At follow-up, a similar percent diameter stenosis, at follow-up binary restenosis rate equal in the two groups. Obviously, the lay lumen loss, as we discussed, was in favor of drug-coating balloon because the gain was also smaller. So this is the primary endpoint of this meta-analysis, which is target lesion revascularization. Here you see the 14 randomized clinical trials, and the two strategies, drug-coating balloon in these selected cases, were doing equally well than the alternative strategy. Here you may see, according to indication, up you see in the top of the slide, small vessel disease. This is the group of trials. Myocardial infarction, a couple of trials. High bleeding risk patients. Well, here, because the comparator was a bare metal stent, the results were actually in favor of drug-coating balloons. And, at the bottom of the slide, all the trials involving bifurcation. And again, you see how the results are consistent overall, irrespective of indication. So you may say, well, in some trials, drug-eluting stents were not used. Well, you may see when drug-coating balloons are compared with drug-eluting stents, you may see how the target lesion revascularization was equivalent to drug-eluting stents. And in fact, drug-coating balloons were better than bare metal stents in the sub-studies where bare metal stents were used in the comparator. So that, what about vessel thrombosis at follow-up? Well, you may see here a strong trend in favor of drug-coating balloons, suggesting that this strategy is safer than the alternative strategies. And here, again, data of many studies putting together the occurrence of myocardial infarction at follow-up. And here, there was a significant difference in favor of drug-coating balloon. So again, safer and reducing by half the rate of myocardial infarction. There was no difference whatsoever regarding cardiac mortality. In this meta-analysis, total mortality was only studied in some small studies, well, and appears to be better for drug-coating balloon, but this is largely unpowered, so we cannot conclude from that. So this is my summary, and with that, I think that we got nowadays enough evidence to support this strategy, so that it's not only that we can use them, but we are also supported by robust clinical data. So thank you, Flavio.
Thank you for putting this data together. I will ask the youngest of the team, Darren. I mean, you were born in the era when stents were already there, and so you didn't have to think whether to leave or with or without stent. How does this data impact your decision-making project when you plan a PCI?
Yeah, so I think that's a great question, Flavio, and I think that one of the issues we need to deal with is physician preparation for the use of DCBs. By that I mean it's very difficult to compare to get a good result with a modern contemporary drug-eluting stent where you do a quick pre-dilatation, you put the stent in, post-dilatation, and your result is pretty much guaranteed. And so this was my contention when these data started to come out. However, over the last number of years, and as we've seen accruing data that DCBs are safe, effective, are not associated with stent thrombosis, where you can curtail in high bleeding risk patients the duration of antiplatelet therapy, and indeed where you can defeat diffuse disease, like in the first case that you showed us. Really, for me, this is a compelling technology that we certainly need to learn more. But I also believe it's a technology that physicians need to start preparing themselves to use, because while the upfront procedure does take some learning and does take some new skills, to not be faced with the not infrequent in-stent restenosis from 50, 60, 70 millimeters of drug-eluting stent in an LAD really it's a little bit more pain up front with I think a lot of benefit in the longer term. And that's why I think that it's worth for us as clinicians to put an extra bit of effort in up front to get that longer term result that may really help some of our patients.
All what you said is very relevant. It has to do with thrombosis, with the stent, with the long term. So this is why we are here. This is why we are talking about the possibility of considering doing some part of the vessel without metals. And I have a very important question from our participants that I will address to you, Fernando, because the Jorge Chavarriga asked, if I plan to do a drug-eluting balloon PCI and then I need to implant a stent, does this patient has a worse outcome?
Well, the data we got from early trials suggested that those patients that the drug-eluting stent strategy could not be fulfilled because a stent was needed was the subset of patients with a higher risk. But in the early days, that in most cases meant implantation of more than one bare metal stent sometimes because of a dissection. So obviously this is the worst population, high-risk population. Now there are many investigators that decide to use a new generation drug-eluting stent, even though we have pre-dilated the lesion, so that when we use new generation drug-eluting stents, well, I think the results are also very good. I don't think we got the data of this subset of patients treated with drug-eluting stents for suboptimal preparation result in recent years.
Okay, thank you. I think that we can summarize saying that if you have to implant a stent after the drug-eluting balloon, the patient will not do worse. I mean, it's like just putting a stent. So, but the question gives us the possibility of going to real life. So please show us the live in the box we have prepared in Verona, because this is exactly what we are talking about. It's a patient that I did some months ago. Can we have the film, please? You will see that the original strategy was that of treating the patient with a mix of drug-eluting balloons and stent. It's a very young patient who went everywhere in the north of Italy asking for PCI because the advice was unanimous, was to undergo bypass surgery. The guy is very low risk. It's practically asymptomatic with ischemia at the stress test, at the high workload. This is a regular right radial access with an extra backup balloon, and there you have. There is a diffuse disease of the left system with a tight stenosis of this intermediate or early oblique marginal branch of the circ. There is some diffuse disease of the distal circ. And the problem is the LAD. You see this LAD diagonal system, very large. The diagonal is as important as the LAD, with a very tight stenosis at the origin. And the LAD has a very diffuse and long disease, some parts of critical stenosis. So the strategy was, let's do all the distal and mid part of the LAD with drug-eluting balloons. And my idea was implanting a stent from the proximal LAD to the diagonal. Okay? Do you agree with that? Do you think it makes sense? Very briefly. Fernando first. Very briefly.
Well, I think it's a very appealing strategy. My bias is that I try to avoid gelling the LED unless there is a very, very tiny LED, a huge diagonal branch. Here, the two vessels are, important, I would say. And I will try to avoid, but I'm expecting to see the result.
Okay. Darren, would you consider this LED for DCB alone, or would you go with stents all over?
No, absolutely. This is exactly the type of patient that I believe can benefit from DCB, particularly the mid LAD beyond the diagonal, the distal LAD, which is diffusely diseased. Stenting this is an extra 80, 90 millimeters of drug-eluting stent And chances are you get some restenosis somewhere if you don't get thrombosis. So absolutely. In terms of the strategy for the bifurcation, I think you could do a variety of different strategies, but the inverse provisional into the diagonal seems appropriate for me, knowing that, of course, you can always add a stent to the LAD if it doesn't look good after you stent the diagonal and optimize in the LAD. So yeah, let's see what it looks like. Okay, let's restart the film. The idea of stenting the diagonal was because it was a better, so that the flow in the distal part of the diagonal would be better. I would have less dissections than going with the stent to the LAD. But of course, this is opinionable. There is no science on that. It's just experience. So the first one is a stent 275, 26 millimeters long from the proximal LAD to the diagonal, and then it's jailing the wire, putting a second wire, and preparing the vessel quite aggressively with a semi-compliant balloon. And this is the initial result after one stent, which was planned. It's not a bailout. And then is vessel preparation and DCB treatment of all the distal and mid part of the LAD with a drug coating balloon. Then, of course, imaging might be good, especially, I would say, not to check the result of the segment you have treated with balloons, because we will discuss this later, but to make sure that the stent is well opposed. You have seen that thrombosis is more frequent after stenting than after ballooning. And you see that the stent is well opposed, and this is the proximal part of the LAD, and this is the non-stented part. And at the proximal LAD, you see a dissection and a calcified plaque in the proximal part. Then these are the main findings. I mean, a well-opposed stent in the LAD and this calcified dissection in the proximal part of the LAD. Good. This is the bifurcation. You see how nicely the carina was reconstructed. And this is the distal LAD with only balloon treatment. So it seems to be good so far. And now is the IVUS on the diagonal. The diagonal distally is okay. And this is a well-expanded stent in the diagonal. You will see again the carina, which is nice. And this is the proximal part. As I said, it's okay. While the native LAD is fine at the edge of the stent, but it has a dissection and residual plaque. So at that point, we went with the angio. I tried to do as less contrast as possible, although this, as I said, it's a young patient. But these are the images. Keep on your mind these images, because we will have to decide what's next. And this is what the angio shows. I remove the wire, and now what you see is the dissection of the proximal LAD, a quite nice, I would say, result of the balloon. Only what is happening to you, Darren? Okay. So what's next? Should we stent this proximal LAD or not? Very briefly. Fernando first.
Well, according to the IVUS criteria, I think the dissection is large and going, right to the media, and it's a proximal LAD where angiographically is something like 50%, I will say. So you can leave that alone. But again, I will say, in this case, I will feel safer implanting a short drug-eluting stent there. Yeah.
Good. Darren, would you put a stent?
Absolutely. Proximal LAD, deep dissection, stent the proximal portion. The distal LAD looks great, though.
So let's go to the film again, and let's see what we did in Verona. This is, of course, discussing about Plan B. There is a change of strategy. We decided to rewire the arteries, wiring the intermediate, and to do what was originally thought, to do the intermediate with only balloon. But you see that also the LAD was rewired with the intention of stenting the proximal LAD. This is balloon predilatation of the intermediate, and then you will see the drug-eluting balloon prevail, the new drug-eluting balloon from Medtronic, 2.5, 20 millimeters to treat the intermediate. Very briefly, I will ask you a question from a friend, Ahum Walil Islam. He said, is it better to use paclitaxel or sirolimus eluting stent? Can we say that? Yes or no? Very briefly.
Eluting balloon, you mean?
Yeah.
Paclitaxel versus sirolimus eluting balloon. Well, I mean, we don't have the data. I mean, the data is strongly in favor of paclitaxel eluting balloon. All the data I share with you, but there is coming data from small randomized clinical trials suggesting equivalence with the limus drug-coated balloons that are 3 or 4 of them.
Okay. Yeah, that's true. We don't know. So the answer for you is we don't know. This is the stent. This is the stent from the left main with a minimal overlap to the proximal LED, to the previous stent, and this is the IVUS. The IVUS, of course, should be done in a left main treatment. This is a young patient. We will not get into details of the IVUS analysis because what we will show now is that we, of course, optimize the stent expansion with a 4.0 balloon. And I think you will agree with that. There is another question which is very interesting, and I will address this question to Darren. Sayan said, you prepared the LED with a 3.0 balloon and you delivered the drug with a 2.5. Shouldn't we use a 1-to-1 ratio? I think it's a smart question, and the guy was paying much attention to the case.
Yeah, so that's a great question, and he's absolutely right. In contemporary practice, it is recommended that we prepare with 1-to-1. We ensure we've got good expansion, and if not, then we need to use alternative devices such as scoring balloons, cutting balloons. Having said that, you could, of course, go to slightly higher pressure with the 2.5 balloon, drug-eluting balloon, because it's a semi-compliant balloon. Yeah, good point. I think you've been caught out there, Flavio.
Yeah, I mean, I am guilty. I have to tell you the truth. This is a public hospital. I wanted a 340. I didn't have the 340. I had a 240, and I inflated it a little bit higher pressure. You know, these balloons are very compliant. But the guy is right. I mean, he was paying attention. Congratulations for the good point. This is the final result. Can you comment on this briefly, Fernando? Are you happy with this result, or you wouldn't leave this as an acceptable one?
Well, I think the stent part is perfect, and the rest of the diffuse disease in the LED is quite satisfactory, considering what is our target here, which is, getting a balloon-like result, but here with a drug.
Good. Darren, would you leave this result or you don't like it?
No, I'm happy. The stented part looks great, as Fernando has suggested. And it's important to know that you don't get a stent-like result with a drug-eluting balloon. You get a balloon-like result. And so if you don't have a dissection that is flow-limiting or extending well beyond the area in question, that you don't have residual stenosis less than 30%, then I think you have to accept that result and know that in the coming months, you're going to get positive remodeling rather than negative remodeling that you get with a stent. So yeah, I'm happy with this.
Yeah, well, this is what we want to show to our colleagues. I mean, you will never see a stent-like result, but the difference will be at the long term. But we leave this for the end of our session. Now we move to you, Darren. We want to know about how to prepare the vessels, how to decide whether to stent or not to stent, if this is safe. And I will introduce this slide to you with a question from Hasim Kadim. He said, nearly 30 to 50% of POVA may need a stent. Is it the same with DCB or not? I think 30 to 50 is very generous for stenting, but maybe he's a young colleague and he needs to be reassured with the stenting. But let's see your slides and your opinion.
Yeah, so Hasim, give me a few moments and I'll get there. So I was asked to discuss, first of all, the importance of vessel preparation. And what I'd like to mention first again is physician preparation. Remember that in EBC main, we learned that you don't have to make a decision to use 2 stents up front. And what I would urge you to consider when you're learning about DCBs and in your clinical practice is that you don't have to define whether you're going to put a stent in upfront. Rather, you can prepare the lesion and then make decisions, stent or balloon. Nevertheless, we do know that stent preparation of vessels is very important, especially when we have the issue of mechanical recoil. So in simple lesions, we tend to give a vasodilator. We consider imaging, though imaging can cause its own problems in DCB realm. And then, of course, we do a pre-dilatation with the balloon. We tend to use a semi-compliant balloon. As the last participant mentioned, a 1-to-1 balloon to vessel size. Sometimes you need to start a little smaller. Maybe in that 3.0, you might start with a 2.5, convince yourself that you're not going to get a big dissection by starting smaller and working up. And then in terms of the length, you need to keep that segment, keep your balloon as short as possible, knowing that your drug-eluting balloon needs to be a little bit longer, both in the proximal and distal end, than the pre-dilatation balloon. If, however, your pre-dilatation is not perfect, don't be afraid to step up and use non-compliant balloons, 1-to-1, cutting and scoring balloons. You always have the option to switch strategy and to use a stent if you're not happy with your DCB preparation. If, however, you don't prepare properly, then you're not going to get a good result from the DCB in the first place. So this is maybe slightly different to what we've learned for drug-eluting stents. In more complex lesions like the one you showed a few moments ago, again, vasodilator, we're a little bit more liberal with our imaging because we want to get the proximal and distal size of the vessel. We want to understand, have we broken the calcium arcs and so forth. And we would usually start with non-compliant balloons, but moving rapidly into cutting balloons, scoring balloons, lithotripsy, and whatever we need to prepare the vessel. Again, we always have the option of placing a stent if we get a deep dissection. It's also important when you're considering more complex lesions to consider the delivery and the transit time of the DCB. So if you're delivering a DCB to a distal vessel and you have a lot of calcium proximally, perhaps you don't want to put the DCB in and then realize that these devices can be a little bit bulkier and that you can't deliver. So you need to think about that in more complex lesions and consider having, for example, a guide liner, a buddy wire, or whatever available to make sure you've got a relatively rapid transit time. Once you've done your preparation, you need to meet the criteria to know that you've done it properly. And those criteria are full expansion, 1-to-1 ratio with the balloon to the vessel, a less than 30% residual, that should be stenosis, residual stenosis, the absence of a flow-limiting dissection. Some dissections are okay. They're not flow-limiting and they will heal. But type A and type B are generally considered okay. But beyond that, especially early in your practice, you can always resort to the stent. And of course, you want TIMI-3 flow. If you're not sure, again, you can consider imaging, or there has also been a call for physiological assessment of the lesion to make sure that your FFR is greater than 0.8, although that benchmark of 0.80 is certainly open for debate. This is an important publication from Robin Jaeger in JACC Cardiovascular Interventions in 2020. It's the third report from the DCB, a consensus group. I'd encourage all of you to get this paper and read it, and that really summarizes graphically what we've just mentioned. Now, of course, what we're interested in is the safety and the efficacy of these treatments. And while Fernando has eloquently described those data, I'm just going to go into them a little bit from a practical point of view, because when you're doing a DCB, again, is that a dissection you want to leave? Are you happy that you're going to get a good result here in the long term? These are things I think that we ask ourselves day to day in the cath lab. So let's start with safety. And if we're going to talk about safety, we need to talk about dissections. And we need to become comfortable again, understanding the grading of dissections and understanding the evolution of dissections. What happens with these dissections? But what we know about type A and type B dissections, and these are essentially small areas of haziness or a linear dissection that is not associated with any contrast staining outside of the lumen. It's not associated with ECG changes or slow blood flow, and we have TIMI3 blood flow. We know that these dissections rarely, and I use that term rarely on purpose, these rarely cause problems. And so these dissections can comfortably be left in the DCB world. Type C dissection, where you have some staining on top of the vessel, that's very much open to debate. And some people believe that this is okay to leave, others are more cautious. And so I think it depends where you are on your DCB journey. If you're starting, I would probably cover these with a stent. And if you're more experienced with this technology, then I think it's open to interpretation. Of course, spiral type D dissections with intraluminal filling defects, or where the vessel is closed, of course you can't leave these, and these need to be treated with a stent. If we then consider this case, a 66-year-old female with a prior CABG, she's got an occluded saphenous vein graft to an obtuse marginal, and she's back with angina. Have a look at these images. We'll just roll through them quickly. And the point of interest here is this mid-LAD. Interestingly, she has a lima on her diagonal branch, but you can see just at the origin of that first diagonal branch and further on around the bend, she's got two tight calcific stenoses. Is this type of lesion a potential to treat with a DCB?
What you think? I mean, I know the answer. So we see your point of view.
So I think this is a tough one. But again, I don't need to make that decision up front. I can wait and I can treat this patient and then make a decision. And so in this patient, they had an aggressive predilatation with 1 millimeter, 2 millimeter, 2.5, and then 3.5 millimeter non-compliant balloons. They had a good result, and they decided to treat with a Prevail DCB. After the DCB, this is what's left. And so, Fernando, Flavio, tell me what your thoughts are here. Fernando, why don't you take us away first?
Well, according to your classification, that would be, what is this, B, C? I mean, it's very clear. There is some haziness in the two edges. This one I will be in doubt. And considering it's a proximal LAD, I think to be in the safe side, stenting that can be much better. Because the other thing is that there is a wire there, so that perhaps these flaps are pushed away by the wire. So, I mean, this is not the result I tend to accept when a drug-eluting balloon strategy. This is a little bit borderline. I mean, you can leave it, and perhaps will be a beautiful result, but I think there is a risk there.
Yeah, and that's a great answer. So in your center, this DCB strategy has not worked. Transition now to a stent, completely reasonable. What about in your center, Flavio? What are you guys going to do with this in Verona?
Well, this is really difficult decision. How the patient is feeling, no chest pain, normal ACG, good blood pressure, there is good flow. If you have a look at these with, for instance, intravascular imaging, you will get very scared and you will never leave this dissection without a stent. If you are used to leave these dissections, as Fernando have shown, the occurrence of acute MI after DCB is significantly lower than after stent. So either we trust that data or we don't trust. So according to this, you will have a higher rate of stent thrombosis than acute occlusion when you remove this wire. Of course, the result will be awful even when you remove the wire, but the great advantage, if nothing happens acutely, will be the long-term follow-up, because you will see a natural curve of the LAD being respected, no restenosis, no impairment of the flow coming from the diagonal that received the mammary artery. But of course, it's a difficult moment when you retrieve the wire.
Exactly. And so this is, I think, a very much a borderline case. I think you, as someone who's done a lot of DCB in your center, you decided to leave this, but you weren't flippant about it. You watched the patient for a few extra days. They stayed in hospital. They did well on mobilization, and ultimately the patient had a good result. But it does show you that even in a result like this, whereby we have probably not one, but two type B dissections, that the result can be very good and can be left. So let's carry on then. Let's ask about what about dissections that are being left behind? Well, this is a really important paper from Bernardo Cortese. And what they did was they looked at their DCB practice, and they took out patients out of 156 patients that had DCBs. They found that 52 of those patients, so almost a third of them, had type A or type B dissections. For this analysis, any dissection that was greater than type B, that is CDE, they did not put this patient in the analysis. They treated those patients with a drug-eluting stent. But in this analysis, where a type A or a type B dissection was left, look at the MACE rates. There's no difference in MACE. There's no difference in myocardial infarction. And there's no difference in patients who had target lesion revascularization. So just because you get a dissection with your DCB does not mean that you have to treat it with a drug-eluting stent. If it's a type A or a type B, you have good safety, and indeed, you probably have good TLR results. If we were to go on and to discuss the safety and the acute procedural safety of DCB, it's important to have a look to think about some of these figures. First of all, what's the risk of bailout stenting? Well, that actually depends probably on the patient population, the type of lesions you're choosing, and on your own experience. Here are 3 trials that Fernando has also previously mentioned, where 20%, 2%, and 14% of patients who were initially identified to have an upfront drug-eluting balloon strategy transitions to a stent. So in the region of about, a fifth or a little bit less of patients will need a stent when you go down this route. What about the risk of abrupt vessel closure? Isn't that why we developed drug-eluting stents in the first place, or bare metal stents and then drug-eluting stents? But lots of things have changed in the meantime. In the pre-stent era, the risk of abrupt vessel closure was about 11%. We certainly can't accept those results. Having said that, in this post-stent era, it's less than 1%. And the DCB era, it's about 0 to 1%. And that's because we understand how to prepare these vessels better. And also the medications are better. The antiplatelet therapy is better. We check ACTs in our cath lab. So there are many other things that help us ensure that we're going to get a good outcome. If we then look at myocardial infarction rates at 6 months, again, these are first-generation DCBs versus first-generation drug-eluting stents or bare metal stents. I would suggest to you that the results in terms of myocardial infarction between 6 and 12 months favor DCB over DES, first generation, or bare metal stents. So in terms of procedural safety, I think we're looking good.
Thank you. I mean, these data, it's impressive. It's not in our mind when we are in the lab. Certainly, we never imagine that it might be safer to leave a lesion without stent rather than stenting, because what we get is the visual impression of a perfect result compared to that ugly dissection that you saw us before. So it's a little bit like accepting a bitter sip to enjoy the sweet of this sip at the long term. But of course, this is what we are discussing. There are some interesting questions. One you have already addressed, using a pressure wire to check whether the FFR distally is lower than 80. You said that it might make sense that you stent a lesion, but I am not aware about trials on that. Are you?
There was a study on myocardial infarction. And in this study, they used the primary endpoint was FFR, and they also used FFR after the infarction. So that, I mean, the problem here, Flavio, to me, is that if you are in doubt and you see this dissection as we saw in the last LED? Well, if you do OCT better than IVUS, because the definition will be better, I mean, you see huge dissection. So in most cases, you will be tempted to proceed to stent because we don't have enough data in de-novo lesion. I mean, how to use OCT to leave or not leave a dissection. We know about the stent and the age of the stents and all that. Whereas if you are in doubt, if you get a FFR of 0.9, this will be reassuring. This will be reassuring for me.
Another question from our colleagues. Does it make any difference whether the dissection is proximal or distal to the treated segment, Darren?
No, I don't think so. You would expect the dissection to be in the treated segment, to be honest, rather than proximal or distal. But again, I think the same rules continue. Is it type A, type B? Are there ECG changes? Is there normal flow? And does the patient have chest pains? And if you don't have any of those features, I think you're good.
So now we have been showing awful results, nasty dissections, and we are scaring our younger colleagues about the kind of cases. But please show us the next slide, which is about a case with the long-term follow-up. And so we will show, no, this is still yours. This is still yours. Darren, you want to finish showing this? No.
Yeah, so I was going to make a quick point about efficacy. So I think in terms of safety, the data is good. And as I mentioned before, that really the efficacy comes down to getting a good pre-dilatation, that is to say mechanical expansion, and ensuring that we have good drug delivery. Briefly, the mechanical expansion we've spoken about, we can assess that using angio, IVUS, or FFR. And then in terms of drug delivery, we need to make sure that we're efficient in terms of our handling of the balloon, that we don't touch the balloon itself, that we get it to the target quite quickly. If you're putting the balloon in and out on multiple occasions, you're going to lose a lot of the drug and you're going to have an inefficient result. As I said before, we need the DCB to be a little bit longer and we need a good duration of expansion. And just again, to give you those 3 studies that I spoke about before, target lesion revascularization, this is really what efficacy is all about. Really, again, there is no suggestion that DCB in these lesions, these were on the smaller side, usually about 2.5, 2.75 millimeter lesions. There's no suggestion that the efficacy of DCBs is lower than first generation drug-eluting stents or bare metal stents. So I just wanted to give some reassurance that Fernando has already mentioned with relation to these randomized trials and efficacy.
Okay, so let's move to the case. This is a young patient, 57, who came with acute coronary syndrome in 2017 with a good LV function. You see ischemia in the anterior wall, and the reason is that the vessel was practically occluded. You see the LAD, there is nothing after the occlusion. This is what you see after a 2.5 balloon opening. Now the flow is good, but you see that there is a diffuse disease distal to the occlusion. At that time, the patient got an absorbed stent 3.523 in the proximal part of the vessel, and the flow now is normal. But again, you see that the distality of the LAD is diffusely diseased, and this we treated with drug-eluting balloon. This is a 30 millimeters, and immediately after, even after the removal of the wire, the angiography is very nice. So what we said before, this is a good example of a nice angiographic result. But what happens if you put an IVUS catheter? Probably you will see what you see here at time 3, a dissection. But what happens if you put an OCT catheter? You will not be scared about this IVUS, but you will be scared about this OCT. Let's have a quick run to the full OCT study of this patient. You will see that the distal vessel is really very small. Indeed, the probe is almost occlusive. And at a certain point, it gets better, but you start watching at the dissection at time 12. And from there, you see the dissection, which looks quite benign, residual stenosis. But at a certain point where the balloon has been effective, you have this kind of intravascular imaging, which is, of course, very different to what you have seen with your angiogram. I mean, the angiogram is reassuring. If you do OCT, you will be worried and you will put a long stent in this very small vessel. This is what we are talking about. So, as I said before, the immediate angiographic result may not be that nice to accept, but what will be good is to see the 4 years outcome. This patient came electively as our control of all the patients treated with Absorb in the past. And what you see is that there is a positive remodeling in the part of where the Absorb has been. And what is amazing is the positive remodeling with totally healed arterial wall at 4 years. You see the enlargement, the point of the dissections with the complete healing of these dissections. So what you see at the long term is definitely much better than what you leave after the balloon alone PCR. So this is to show you one out of many cases. We don't have many cases of long-term follow-up, and I think this is one of the main limitations of the data we need to convince ourselves and to convince our colleagues to trust on the efficacy, because we have been focused on the safety and trying to show you that there is no more infarction, no more thrombosis, but still we have to accept this suboptimal angiographic result compared to stents. But when you have an angiogram after 4 years and you have this vessel with no metal, with no foreign body, with no neoatherosclerosis, which is moving physiologically, you have vasoconstriction, vasodilation, because there is no cage. Probably this will be an advantage for the future. But of course, this is open to discussion. Let's discuss together on this point, which I think is one of the main strengths of this philosophy. Alfonso, you have done many trials. You have experience also in acute MI, and there is a question from John Mc asking about what to do in acute MI, if this can be an option. I want to hear your opinion on the long term and the use of DCB in acute MI.
Well, there are several issues I would like to discuss briefly. I mean, we got that if we do OCT in stent restenosis, you see these ugly dissections hanging within the lumen, but there is a stent. So we got plenty of information that this is healing properly at follow-up. In the de-novo lesion, using drug coating balloons, we don't have this information. I mean, there is little data suggesting how OCT can be used to optimize or to decide. If we use the criteria we use in stents, perhaps we should be a little bit aggressive, because, for instance, the dissection you left there initially, for the stent word, even at the edges, that will be meeting the criteria to stent. And that will have been a mistake because you saw a very, beautiful long-term result. Regarding acute MI, well, there is a study, as I told you, using FFR as a means to say, well, I don't care about the lumen diameter or whatever. I want to see what is the FFR in this patient with myocardial infarction. And this can be used. In my experience, this is with Tuchar from Madrid also, running some studies where at the beginning the use of drug-eluting stent in myocardial infarction were of concern because of a higher risk of thrombosis. This is the beginning. Well, there were some people using bare metal stent. So I got experience with the strategy of using a drug coating balloon and then putting a bare metal stent. There are a couple of studies by Tuchar in Madrid that we performed. The results are good. I don't think this is the strategy we are facing now. And I have to admit that in most acute patients with myocardial infarction, I try to put a stent in the culprit. By the way, the case you just showed is very interesting because, in the acute MI, you should treat the culprit. But when there is a wire in the same vessel, leaving a lesion that is severe, as in the case you treat in the mid-LED with a drug coating balloon, is very unique. You can say, well, we treat the culprit. Let's see if tomorrow, the patient is stable and perhaps this lesion is not so severe. But again, in this setting, I try to treat everything which is in my wire. Okay, I don't leave lesions adjacent to the culprit in the vessel I'm treated. I can think and stop for other lesions, but I try to fix everything in the vessel I treated. And to finalize this a little bit, I don't have much experience in acute MI opening the vessel with or without thromboaspiration to allow the drug-coating balloon to be effective in the vessel wall, and just using a drug-coating balloon alone strategy.
Okay, there is another interesting question. It says, often it happens that when you stent, you have low flow. Is that a good option for a balloon alone, avoiding the stent in acute MI? Darren?
Yeah, I think as Fernando has suggested, there's a lot that we don't understand about acute MI, because of course acute MI is a different process. Sometimes it's a plaque rupture, sometimes it's a plaque erosion. Do we know that those lesions will be well treated with a DCB? I would suggest we don't. And of course, if you've got a lot of thrombus around the vessel and you're inflating a balloon, maybe your drug goes into the thrombus, which ultimately clears, and not into the vessel wall. So I think conceptually there are some issues with acute MI, but I would suggest that the participant is correct. There's quite a few acute MI cases that I don't put any stent, that I will reestablish TIMI3 flow, allow flow to reduce the thrombus burden, marinate the patient in antiplatelet agents, sometimes a GP2B, 3A inhibitor, and come back and consider placing a stent at a later date. And I think that we have evidence from Colin Berry's group, the DEFARE-2 study, that suggests that that's a very reasonable approach when you have a high thrombus burden. But the role of DCB in that, I'm not entirely sure.
Okay, we have 3 minutes left and so many questions. So I ask you to be very, very concise with the answer, because these last 3 I have selected are very important. Which is the long-term the antiplatelet therapy after DCB? Fernando?
I will say 3 months.
Of dual and then single?
Yes.
Okay. Bifurcations, Darren, is that a good indication for DCB, treating the side branch or a bifurcation with 2 drug-eluting balloons?
Yeah, I'm a provisional stent guy, and so I like the option of provisional stenting. And then when I have a long lesion in the side branch that really doesn't look great, I like doing a final kissing with a DCB in the side branch and indeed a stent in the main vessel. Can you use 2 DCBs? Absolutely. This can give you a very nice result. You don't have a metal carina. You don't get carina shift. So yes, this can be a good option.
Still, it is not recommended. It's still not in guidelines. It's just practice, but we have no evidence on that. Last question for you, Fernando. This is a very smart one. If drug-coating balloons work in long disease, small vessels, should it be considered also for large vessels, short lesions?
Well, this is a very nice question, and there are studies transformed by Bernardo Cortese and other studies trying to address that, so that trying to predilate, get a good result, any kind of vessel, any kind of lesion, and if the results are good, you go and randomize, and we are doing that.
Fernando, I have to tell you, there is a criticism to your previous answer. They say 3 months, I would suggest 3 months does not provide a lot of certainty. Are you? What?
Well, I mean, in some of the documents, do you say that 1 month is enough? In some of the documents, which is fair enough. But to me, if there is, unless there is a high bleeding risk, I think 3 months is, a sweet spot in the middle.
So minimum 1 month, like in the good old balloon alone PCI. Then for safety, low bleeding risk, you keep other 2 months. Okay, guys, we are 40 seconds apart from the end of this wonderful time spent together. I hope our colleagues have enjoyed it, but especially that they take a good message out of it. I want to thank you, Fernando and Darren, because you have been clear, concise, perfectly on time. I want to thank, of course, PCR for giving us the opportunity of sharing our experience, our knowledge with our colleagues. of course, Medtronic for supporting with an unrestricted grant this interesting webinar. And what to say? I say you goodbye. If you want to say goodbye to our colleagues, hope to meet you the next time somewhere.
Okay, no, thank you to everybody. I enjoyed the meeting and I learned.
Ciao, everybody.
You say it in Italian. Great. Thank you.
Bye. Good night.